Good morning, everybody. I want to welcome the attendees to the Virtual Rheumatology Learning Collaborative. And before we get started for our talk with Dr. Odell, we're going to do a couple of housekeeping items. The first is that you'll see on this web interface, there's a chat button that can be used for kind of any general comments, but it's not where we would want you to put your questions for Dr. Odell at the end. There's a raise your hand button that's to be used if you're having any problems with the system in general. And then finally, the Q&A button is where any kind of questions related to the content of the talk, we'd ask you to leave that there, and then we'll try to pick out some of those to ask Dr. Odell at the end of his presentation this morning. And then also we'd ask, we all get emails within 24 hours notifying us that the content's available to be viewed. And then there's also a link to a survey that we'd like you to be able to fill out for an evaluation for Dr. Odell's presentation. And then at the end of this whole series, there'll also be a survey about the initiative in general as well. And so today I'm one of the co-moderators. I'm Jason Koffenbeck. I'm at the University of Colorado. I'm the program director there. And I'm also joined by Jean Lin. She's a second-year fellow at Northwestern. And then I guess without further ado, we'll introduce Dr. Odell. Dr. Odell comes from the University of Nebraska, where he's the chief of the Division of Rheumatology, and he's also the vice chair for education for the Department of Medicine. His list of accomplishments and publications are too long to kind of elaborate on fully, but I think just some highlights are that for 30 years, he was the leader of the Rheumatoid Arthritis Investigator Network. That's a collaborative of rheumatologists across 7 states whose goal it was to conduct large non-pharma sponsored clinical trials to answer kind of relevant clinical questions. That resulted in numerous publications, including 3 of the New England Journal of Medicine. And also, more importantly, it really changed the way we practice. 15 years ago, it was not uncommon for folks to move immediately to biologic therapy for someone with quote unquote high risk RA. And I think the studies that Dr. Odell and colleagues did, including the TIER trial, really gave validity to triple therapy as a viable option. He's also been a past president of the ACR and the RRF. He's the section editor for rheumatology for Up to Date, and he's an editor of Kelly's Textbook of Rheumatology. So without further ado, we'll turn it over to Dr. Odell.
Well, thank you very much, Jason. It's terrific to be here today. It's a huge honor to talk to all of the fellows across the country about anything, but particularly about rheumatoid arthritis, which is clearly our most important disease. It's a little bit of a dubious honor because it's also the disease that you all know the most about. It's an honor also to be able to follow Mike Weinblatt and his excellent talk that he gave a couple of weeks ago. Mike and I think a lot about this and have for many, many years. Both of us came up in the pre-biologic era. And so you're going to hear a little bit more about methotrexate. Mike emphasized that, but I'm also going to cover a number of areas that Mike didn't cover because of nobody can cover everything. So the title of my talk is Using All the Tools in Your Toolbox. And this is something that I think is really critically important. And I'm going to show you some data, and Mike actually alluded to it in his talk, that shows us that we're not doing a very good job of that. And I want to emphasize some of these other tools that many people don't spend any time talking about. You're not going to hear about many of these other drugs because nobody's making money on them, et cetera. But you have to know about them if you're going to practice good rheumatology. So here's my disclosures, and Jason actually highlighted a couple of those already, and some of that is with our work with triple therapy and whatnot, so intellectual conflicts there. One of the things I hear an awful lot is from people is, well, since the biologics, everything is terrific and wonderful, and implying that they're the answer, and they're not. So they're wonderful, but they are in no way a specific treatment for RA, nor do they cure RA. We don't understand the cause of RA. We're treating cytokines that are important in RA or something like that, but they're not the cause of RA. And so don't get caught up into that kind of thinking. They're extremely expensive and have serious toxicity in a very few patients. So most of the time they're tolerated terrifically, but if you use enough, you will have really bad experience in a very few people. And we're getting better at predicting those people, but it's still a problem. So they're not the whole answer. I hear that things are so much different since biologics, but actually things are different for many, many other reasons. And this slide highlights a bunch of those. Earlier diagnosis, the importance of early DMARD treatment. These are not things that were done 25 years ago and are clearly done now. More generalized effective use of methotrexate. Mike highlighted this. I'm going to go back to there, make some other points about methotrexate, particularly with switching to sub-Q therapy. The universal use of combinations. In the 90s, nobody used combinations. It's amazing to think about that. When we did our original triple study, the FDA only allowed us to use a gram total of sulfasalazine when we combined it with methotrexate. That was the thinking at the time, changed dramatically. The most important thing that's happened in the last 25 years is the realization of treating to a target, and I'm going to address that. Again, I'm going to go through some of these slides quite rapidly this morning because of the amount of material I want to get covered. And again, you can review these and particularly go back if some of the references or things you want to look into in more detail when this is posted in 24 hours. And to that point, these are 6 studies that I really, really want to highlight that I find that fellows don't know very much about. When I used to be able to travel and we'll go around the country and meet all the fellows, which I really, really miss, these are some of the things I would want you to understand. And the use of folic acid, treating to a target, et cetera, et cetera. So go back and review these studies, know them, and that will help you be a better rheumatologist. So what's a joint like this doing in a nice girl like you? Well, that's kind of what it's all about. We got patients, we want to do the best we can for them. What kind of expectations are you going to give this patient about her disease? And that's critically important. And the expectations should be really high, and we should make diagnoses really early. So the new classification system allows us to do that primarily because it takes away the 6 weeks. But of course, if you're taking a quiz in rheumatoid arthritis, on boards and stuff, never ever start a DMARD in that 6-week window unless the patient's CCP positive. So in the new classification criteria, you get halfway to a diagnosis of rheumatoid arthritis by having high titer CCP or rheumatoid factor. It doesn't require 6 weeks of disease. This is the study that puts CCP on the map in terms of its diagnostic usefulness in RA. And this study is now over 15 years old. Basically what this study says, in 318 patients that had inflammatory arthritis but couldn't be classified as having rheumatoid. What it said was if they were CCP positive at time 0, they went on to develop rheumatoid arthritis. This says 93%. If you use the new classification criteria, it's 100%. So that patient who comes in with inflammatory arthritis, they're CCP positive, you can take that to the bank. I'm very grateful for this in the virtual rheumatology era that we're in right now, because even if I see a new patient with classic symptoms virtually, I can't squeeze her joints, et cetera, but if she's high titer CCP positive, I feel pretty comfortable with that diagnosis. And this is the data that really put that on the map for us. And so know this study. Very important to talk about atypical presentations. You're all very good at recognizing the standard case, but what about those atypical presentations? And CCP is really, really helpful in this particular category of patient as well. And I have a series of patients who now present with their monoarthritis, and I can remember these patients from 25 years ago or whatever, and I wish I had the ability. And certain activities lead to certain joints being that initial joint that presents with RA. I have had several ice skaters who come in with ankle injuries because they jump a lot and land on their ankles. Hockey players with shoulder problems. Tennis players always present with wrist problems, et cetera, et cetera. And monoarthritis is very difficult. Sometimes it's oligoarthritis. So when we see these patients, historically, we'd culture their fluid, it would be negative, and then the operational thing was to get a biopsy so you could culture the synovial tissue itself. That's how you're going to find TB. That's how you're going to find fungal infections. That's still really important. But if everything else fits and that patient's high titer CCP positive, that's rheumatoid arthritis. If the cultures are negative of the fluid, and you can take that to the bank and you can get your therapy going. Historically, I'd have to wait for these people to kind of declare themselves with more joints involvement. I don't have to do that anymore, and that's terrific. So I wanted to say a few words about atypical presentations. So now back to this patient. Setting those expectations are really important, and you and the patient should have very high expectations. And part of that is making sure that you're treating to a target. When we initially were doing studies on this, and we were designing studies around treating to a target in the 90s and early 2000s, we were amazed. I was amazed how poor a job that I was doing in terms of actually getting people to targets. I thought I was doing a pretty good job, but when you actually look at those numbers, they keep you honest. And so it's not so important what your target is, and the ACR is now just coming out with new approved disease activity measures and stuff. It's not particularly important whether you use a rapid 3 or a DAS28 or PASI or whatever. But it's very important that you use something. And this is a study that put that on the map. This is the Tacora trial from 2004. They treated to a target intensive therapy, and note that they only used non-biological medications to get there. But what they showed was a dramatic difference in the people who they did usual care in versus those who they actually treated to a target in. And these rheumatologists in Glasgow are some of the best in the world. This is Ian McGuinness's group. And so don't say, well, they weren't very good rheumatologists, they didn't treat very well. These are some of the best rheumatologists in the world. But even when they treated to a target, it made a huge difference. So critically important in terms of your expectations for the patient's expectations is to treat to a target, whatever it is. So should that target be remission, or is low disease activity good enough? Okay, well, obviously remission is wonderful, but it's not achievable in every patient with acceptable toxicities and expense. So this is where some of the art of medicine comes in, and it's great that we still have some art of medicine and rheumatology. There's no clear answer whether in every individual patient whether remission is better than low disease activity. It depends upon what it takes to get there. If they only have one joint involved and the next step is adding a biologic or adding something else that you're worried about the toxicities in or the expenses prohibitive, then maybe low disease activity in some patients is good enough. But clearly have a target, measure that target, and treat to that target. Okay, so back to this patient, Miss Pip, we'll call her. Typical, classic, easily recognizable rheumatoid arthritis, symmetrical swelling of her PIPs, etc. So what are we going to treat Miss Pip with? Well, this is what we do in Nebraska, because the bottom line is we don't know what to treat Miss Pip with. That's one of the holy grails in rheumatoid arthritis, is trying to find parameters that help us predict who's going to respond to what medicine. And many of us have spent lots and lots of time and money looking into this question. We still haven't cracked that nut. So we're still back to clinical judgment. And so in Nebraska, we just have a wheel, we spin it, lands on a therapy, and we go in the room and act like we know what we're doing. So I'm making fun of us because we don't have the right answer for every individual patient. And when we get there, and I think we'll make some progress, we'll get there. We have nothing there that's helpful right now, but we will get there eventually. So short of that, we have to make a choice. And clearly, we have lots of options, and that's terrific. So we have 23 disease-modifying drugs now that are approved for rheumatoid arthritis. That's an amazing statement. And we use these in combinations. And even if we don't use some of these older medicines that nobody uses anymore, and of course we don't combine biologics or JAKs, we still have over 3,000 combinations to use. That's pretty daunting. And that's why every patient with rheumatoid arthritis has to have a rheumatologist taking care of them. So what are we going to do in the standard patient amongst all of these choices we have? Well, the answer is methotrexate. Methotrexate is the best disease-modifying drug. Absolutely no question about that. And if anybody challenges that, then there's overwhelming data that this is the right answer here. So it's most effective. There has never been a biologic that ever beat modestly dosed methotrexate head-to-head. Okay, some people will argue with that. There is no data that addresses that, and I can show you study after study after study. JAKs have beat methotrexate head-to-head, but only when methotrexate at very suboptimal doses and a route of administration has been used. No JAK has ever beat methotrexate subcutaneously. It's the cheapest by orders of magnitude, especially when you use it subcutaneously. It's safer than biologics or JAKs. Almost all studies have shown at least a twofold increase in serious adverse events, particularly infections of the biologics or the JAKs over methotrexate. And that's important. It's important for a small percentage of our patients. Tolerability is an issue at times. It's mitigated by folic acid. That's why those studies that I highlighted up there up front for you, Sarah Morgan studies in the 90s to help us use folic acid with methotrexate were critically important. And know that data and use folic acid daily up to 3 to 4 milligrams if you need to for the methotrexate flu. But also understand that when you switch from methotrexate orally to subcutaneously, you have a marked improvement in tolerability in terms of the GI toxicities. So based upon many blinded studies, 30 to 40% of people will get to low disease activity with just methotrexate alone, even when it's dosed suboptimally, 20 milligrams, up to 20 milligrams orally. Other studies, observational studies from Europe and particularly from Canada and Carter Thorne's group up there, will show that if you use subcutaneous methotrexate in doses up to 25 milligrams, you can get 50 to 80% of patients with rheumatoid arthritis at least into low disease activity or better. Really important information. We are not using that very well. So no therapy has ever beat optimally dosed methotrexate. Anybody who says otherwise doesn't know the data. Here is some of that data just to show you from a pharmaceutical study. Okay, here's the premier trial. It was adalimumab against methotrexate versus a combination. And here's adalimumab against suboptimally dosed methotrexate, only orally. Mean dose of methotrexate for this group was 16.9 milligrams. And there it is, ACR20s better than adalimumab. Standard dose is 40 milligrams every 2 weeks, both for ACR20 and ACR50. Head-to-head, methotrexate beats adalimumab. Okay, so with that information, we should be using methotrexate and we should be using it very well, and we're not. So Mike referred to this study when he talked 2 weeks ago, and I want to go into it in a little bit of detail because it was our trial, it was our study. And we looked at 272 million covered lives in the United States, so a pretty good sample. And we found almost 50,000 RA cases, new cases in 2009. And the reason we picked 2009 is we wanted 5 years of follow-up on all these patients when we were doing this study. And we looked at those and we looked at what they got as initial therapy, we looked at what they got and when they started biologics, et cetera, et cetera. And before you cast aspersions of this data, because some of it wasn't from rheumatologists, but 73% of it was. So mostly it was us out there doing this. And what did we find? Well, we found some very disturbing things. We found that 27% of patients got a biologic before they had ever seen methotrexate. Many of those before they had ever seen another DMARD. Some people say, well, how do they do that with their insurers? I don't know, but they did. The mean dose of methotrexate when patients were started on a biologic was 15 milligrams. Okay, methotrexate has increasing efficacy up to at least 25 milligrams. Not good. 50% of people had a biologic started at 3 or less months of methotrexate. Methotrexate takes at least 6 months to reach steady state. So many of the trials that you see done that have methotrexate have only been going on for 3 months and then continuing methotrexate. A lot of the benefit that those patients are getting is because methotrexate's working better as they go forward. And only 7% of people in this database that we studied, 272 million covered lives, got subcutaneous methotrexate. So we're doing a lousy job out there in terms of using methotrexate and using it optimally in our patients with rheumatoid arthritis. There's many explanations for why that may be true. We don't have time to go into that today. So the other title for this talk might be Tilting at Windmills. I realize that some of the things I'm talking about are not what's happening out there, and I think that's wrong, and I think we're not doing things right with methotrexate and our other drugs, which I'm going to talk about here next. And unless we're doing this right, then we're not practicing good rheumatology. So let's go back to methotrexate and talk a little bit more about a few details. And then by the time you get done with this talk and the talk that Dr. Weinblatt gave, you're going to be tired of hearing about this, but hopefully you'll utilize it better. So you're going to avoid methotrexate in women who are considering conception, obviously. You're going to avoid it in CKD. You're going to avoid it in a patient who drinks excessively. And of course, we've changed that. Many of you don't know that when we first used methotrexate, we didn't allow people to drink at all, zero. And of course, we've liberalized that greatly now. 1 drink a day is probably okay, et cetera. So we don't know what excessive is. And you're going to be concerned about methotrexate in a patient with lung disease, not because methotrexate causes interstitial fibrosis. There's no evidence that that's true, but it clearly causes pneumonitis. I shouldn't have to say this, but when I traveled around, I used to have people ask me this question. In the rheumatological world, methotrexate is always a once-a-week therapy. Do not use this 3 times a week like Epic has a default to, or whatever. Liver toxicity will happen, and that's what happened in the 70s, and that's why methotrexate got a bad name. It's a once-a-week therapy, only on the day they take methotrexate. We'll talk about split dosing in a minute. So we did that in Miss Pip, and she did reasonably well. She went from a joint count of 12 and 14 down to 3 and 2. We had escalated her methotrexate from 15 to 20 milligrams, but she's been on that for 2 months now, and she still has 3 tender and 2 swollen joints, and so she's probably on low disease activity, but we'd like to get her in remission if we can, and that's great. So what are we going to do for Miss Pip? We're going to go on triple therapy, switch her to subcutaneous methotrexate, add a TNF inhibitor, or put her on a JAK. And the answer clearly here is switch her to subcutaneous methotrexate. Okay, that is clearly the right answer here, and whatnot. And so that gets to the use of optimal methotrexate. And again, Dr. Weinblatt talked about this a little bit. I'm going to make some additional points here with some additional data, and hopefully we'll get through to you. Is oral methotrexate well absorbed? No. We don't know who's absorbing their methotrexate and how much they are. And I'm going to show you a data on absorption of methotrexate here in just a second. Oral methotrexate absorption is dose dependent? Absolutely. So that's really important to understand. When we start to get to that 20 milligrams, and I'll show you that curve, it starts to bend and is less well absorbed. Split oral dosing improves efficacy. Dr. Weinblatt talked about this. Absolutely true and very important and seldom done. Subcutaneous methotrexate improves viability dramatically. Really, really important. And it also improves tolerability. So that's really important for you to understand. Peak efficacy is reached by 3 months. No, it takes a minimum of 6 months to get all those polyglutamated things going on in the nucleus to have methotrexate be optimally effective. And when you're reviewing studies, and methotrexate has only been on board for a short time before the study starts and people aren't continuing on methotrexate, a bunch of the benefit that patient's still getting is going to be from their methotrexate and not from the new therapy. And that's why in a lot of our trials, the methotrexate people, the so-called placebo group, actually does pretty darn well and has very little radiographic progression. Injectable methotrexate can be mixed with juice and taken orally. Yes, and this is something that fellows tell me they never heard of when I travel around the country. So it's very, very, very important for you to understand that. So here's that slide I promised you on bioavailability of methotrexate. These are 41 patients, and this is they took the same dose of methotrexate, and this is the bioavailability. It's all over the map. So there's no way that you know or I know by looking at a patient or doing anything else we do when we could even see them in person, that we know whether they're a good absorber or a bad absorber of methotrexate. So if they're not getting the efficacy that you expect, you need to push the dose and you need to think about switching to subcutaneous methotrexate. And this is the slide that I wanted to emphasize in terms of the dose and how the absorption goes down as the dose goes up. And this curve bends someplace between 15 and 20 milligrams. So when we get to that dose, that's when we should be considering splitting the oral dose. So they take their methotrexate on Saturday as an example. On Saturdays as an example, they take half of the dose in the morning, half the dose in the evening. You emphasize to them it's only in that 24-hour period where they're taking their methotrexate. You split the dose, they get increased bioavailability. Better switch them to sub-Q at that time. And at every dose, better bioavailability and no dependency in terms of absorption or bioavailability based upon dose. Very, very important information. Here's some data from Canada when they use sub-Q versus oral in terms of success and continuation rates of sub-Q versus oral, markedly different. In some of the data from the CATCH cohort that they've published, only 10% of their cohort needed to go on biologics because they used subcutaneous methotrexate effectively. Really, really important data for all of us. So methotrexate also makes every DMARD that we use better, with the possible exception of the JAKs. And there's very strong evidence of that in the literature, and you need to know that. So all of our traditional DMARDs are better with methotrexate. All of the TNF inhibitors are clearly better, and there's great studies on that. I just showed you the premier trial. I'll show you the data again and again. Rituximab, etc. The evidence in tocilizumab is weaker. Depending upon how you look at it, there's evidence there that methotrexate makes it better, but it's weaker. And in the JAKs, there's also some evidence that they improve. They meet criteria when they're using the combination versus the single drug, the JAK, but it's less evidence. But in general, all of your DMARDs are made better, and there's a variety of reasons for that. Sometimes it's bioavailability. It increases the bioavailability of adalimumab and infliximab. And sometimes it's anti-drug antibodies, and we'll get to that in a minute. In addition to methotrexate, it's really important that you use all the tools in your toolbox. And what do I mean by that? I mean, there are other biologics, there are other non-biologics out there: hydroxychloroquine, sulfasalazine, leflutamide, azathioprine, minocycline. If you're not using all of these drugs in a small niche of patients in your patient population, you're not practicing good rheumatology. You're practicing rheumatology with one hand tied behind your back. And so what are the niches where you should be thinking about these other traditional biologics in? So I'm going to go through a series of things that I call using the right tool. So we got a patient who's a methotrexate candidate, but they have CKD4. Well, you're going to stay away from methotrexate in that. And so what drug are you going to use? You're not going to go right to a biologic. You should be using leflutamide in that patient. Very, very important to understand that. Got an RA patient who wants to breastfeed. That patient, you should be using hydroxychloroquine. Hydroxychloroquine is a very good DMARD. Maybe it doesn't work for COVID, but it's a very good DMARD in rheumatoid arthritis, and I'll come back to that. You have an RA patient who's got ILD. You're going to shy away from methotrexate, not because the methotrexate is going to make their ILD worse, but because it's going to confuse the issue. If you're always going to worry, do they have superimposed pneumonitis or something like that? Azathioprine is a great drug for that patient, and I'll show you a little data on that in just a minute. You got patients who don't like any labs, and they have frequent infections. Well, that patient is a terrific patient, very small niche for these patients, but this is a terrific niche for minocycline. Go back to the 90s, look at the data, a pretty good DMARD for rheumatoid arthritis. I'll show you a little bit of that data. They need a biologic, they have a history of lymphoma. You're going to shy away from TNF inhibitors in those patients, or you should. And what are you going to use? You're going to use rituximab. Again, using the right tool. They're in remission, but they're developing nodules. So methotrexate causes a nodulosis syndrome in a few patients, and maybe you've seen that, you will see that. It's almost always in the patients who are doing spectacularly well on methotrexate. they develop these nodules, and that's problematic. And so you need to do something different with them. Flutamide and thiopurine are exactly what you ought to do with that patient. Their nodules will stop progressing, usually regress, and many of them will do terrific. They're obese. They've got a strong family history of diabetes mellitus. That patient has to be on hydroxychloroquine. If they're not, you're not practicing good rheumatology. So you can also use the wrong tool, all right? So you got a patient with rheumatoid arthritis who's got a history of melanoma. You're not going to use abatacept in that patient. It does exactly the opposite of what the metastatic melanoma drugs do. It damps down this, it inhibits the second signal as opposed to ramping up the second signal to T cells. So we don't have any direct evidence, but common sense tells us this is exactly the wrong thing to do for that patient. And if that happens and the melanoma becomes a problem, I can guarantee you're going to end up in court. You have a fear of zoster. Well, obviously you're going to avoid the JAKs. We hope that Shingrix is going to be the answer to this because it's a big problem in our patients, and we'll see. We don't know the answer, whether that's going to take care of the whole problem or not. Patient who has frequent lung issues, the common COPD is pretty common in our patient population. If they have a COPD exacerbation all the time, then methotrexate is problematic because every time they have a COPD exacerbation, you're worried that they're one of those tiny percentage of patients who might have methotrexate pneumonitis. So you're going to need to do something different in that patient. So you're going to avoid methotrexate, okay? History of diverticulitis, everybody knows you're not going to use the IL-6 inhibitors in that patient. Maybe you're not going to use the JAK inhibitors. There's some data on that now, unless you're forced to. They have a weight loss problem. Well, this may be one you don't know, but flutamide is well reported to cause weight loss. And that's good for many of our patients, okay? But it's not always, all right? You get somebody who's really vain, they work as a model. Well, minocycline is probably not a great plan in that patient because of the hyperpigmentation that it can cause and whatnot. They got CCP positive rheumatoid arthritis, but they have the new onset of psoriasis. Okay, they didn't have psoriasis before, now they have it. You're going to stop your TNF inhibitor. Okay, TNF inhibitors can cause psoriasis. It's something you should all know, and I'm sure you probably do. You got a smoker on birth control pills? Well, you're clearly not going to use the JAKs in that patient population. So use the right tool, but avoid using the wrong tool. Really, really important. So with that, let's talk a little bit about some of the rest of these disease-modifying drugs that don't get used very much anymore, which is a shame. So here's a patient who doesn't want to have lab drawn and whatnot. And so we see these patients, and I'll give you an example of one in just a minute. So what's the right answer for this patient? Well, hydroxychloroquine is a great drug for rheumatoid arthritis. There's the one with the least evidence of radiographic benefit, and that's because it's never been looked at satisfactorily. It works really well. It does a lot of wonderful things, including prohibiting 70 to 90% of our patient population from ever developing type 2 diabetes, and that's why this is important. So kill two birds with one stone, prevent the diabetes that this patient would have otherwise had. It's the safest DMARD we have, at least for the first 10 years. Minocycline and sulfasalazine will also be options in this lady because minocycline requires no lab. Sulfasalazine requires lab in the first 6 months and then requires little or no lab after that. So a case for sulfasalazine, this is courtesy of our program director, Dr. Canella. So you got a patient who's rheumatoid arthritis, she's on hydroxychloroquine, but she's got breast cancer, she's got a little renal issues here, she's lost a bunch of weight, her oncologist put her on tamoxifen. So some of the things you need to know about hydroxychloroquine is that tamoxifen, doses greater than 5 milligrams per kilogram, duration more than 10 years, et cetera, all of those are risk factors for increased toxicity. And all of those should make you think about, maybe I should be doing those screening eye exams earlier. Right now, the American College of Rheumatology has a task force that's working with the ophthalmologists to put forward with brand new recommendations for a monitoring. and we're actually meeting to finalize those recommendations tomorrow, virtually, of course. And they're going to look a lot like what they used to be, but they're going to emphasize that OCT is the way to screen for early hydroxychloroquine retinopathy. And so all of our patients should be having that done. And here are some data that speak to all those points I just made. I'm not going to go through this in detail for you, and you can review it at your leisure. That talks about dosing, talks about tamoxifen, talks about renal insufficiency, all of those things we should be thinking about in patients who are using hydroxychloroquine. That doesn't mean we shouldn't be using it, but that may mean we want to ramp up our screening of those patients. So some caveats: it's the safest DMARD. It's my favorite DMARD for side effects. What do I mean by that? It lowers your cholesterol. It improves your HDL function. It decreases your chances of developing diabetes by 70% in the rheumatoid population and also in the lupus population. It decreases platelet adhesiveness. So it does other really good things for our patients who are going to have an increased incidence of coronary artery disease and strokes, et cetera, because of their inflammatory disease. Emphasizing that optical coherence tomography. And if you've seen any of these pictures, if you've seen any of those studies, you can see the thinning. Even I can see the thinning around the central area there that you get with OCT. It's pretty cool, and clearly what we ought to be doing to monitor for this going forward. And if we do, nobody's going to have visual loss from this drug. You get a rare retinopathy, myopathy, neuropathy if these patients have been on this drug for a long time. This is where you're going to see this in the lupus population. They've been on the drug for 20 years. You're taking the quiz or boards. The key thing on EM is curvilinear bodies. EM shows curvilinear bodies. That's hydroxychloroquine toxicity. So do you use azathioprine in the treatment of rheumatoid arthritis? Many of you are saying, well, no, I can't remember a patient we had on that. That's wrong, okay? You got to be using this in a subset, a niche of your patients. Where is that niche? Interstitial lung disease is one of those niches. So the interstitial lung disease, the ILD docs will have us try to use CellCept. CellCept's a lousy drug in rheumatoid arthritis. So you can't kill two birds with one stone there. So that's an ideal patient to consider azathioprine in. You're not worried about methotrexate pneumonitis, et cetera, et cetera. So is that patient who's got the nodulosis from their methotrexate. Those are patients you should be thinking about using azathioprine in. An FDA-approved drug. It's a good drug. You don't hear about it anymore. Nobody's making any money on it, but it's a good drug. There were some studies in the early 90s to show combinations with methotrexate may be beneficial. Those were never followed up on, again, because nobody was supporting it. Still a good drug in RA for a niche of patients. You should be using it in a small niche of your patients. So here's some data. It's also safe in pregnancy, or relatively so, and it works very well with combinations with methotrexate and hydroxychloroquine. You use methotrexate azathioprine combinations not uncommonly when you're treating polymyositis, or you should, because it's a very effective combination in that setting. So why not in rheumatoid arthritis? Well, there's data to support that in RA as well. It's proven to decrease anti-drug antibodies. So we think about methotrexate in that context, but it's because azathioprine does that too. And so in the patient you're worried about that and who can't be on methotrexate, azathioprine should be a go-to there. This is some data from Dan McCarty. He did studies, sorry the reference isn't coming through there very well, in the mid-90s. All of his studies were observational rather than blinded, which is kind of the standard back there 25 years ago. But he showed very, very good efficacy when the combination of methotrexate, azathioprine, hydroxychloroquine were used. Something to think about. You're probably not going to see studies on this. Nobody's going to support it. A niche of your patients. Think about that. Okay, so I had a patient. He called himself homeless. He really had an RV. He traveled around the country. He came to me after another rheumatologist fired him because he told the rheumatologist he was only going to see him twice a year and he didn't want to have any lab. He just retired. He wanted to travel around the country. So what did I do for him? I put him on minocycline. He had CCP positive rheumatoid arthritis. This should say 100 milligrams BID, sorry for the error there. What was the result? 8.5 years of remission without progression of his rheumatoid arthritis and 3 worn out RVs, okay? Extraordinarily happy guy. After 8.5 years, he was coming back to Omaha, spending more time in Omaha. He needed some methotrexate because his disease was starting to flare a little bit and whatnot. But a great story, couldn't have been happier. One of my favorite all-time patients. Another patient that I share with Dr. Canella, and this patient also was a terrific niche patient for minocycline. Again, it's a small niche, but there's these patients out there. This patient had an incredible history of failure, but he also had an incredible history of comorbidities, survived lung cancer, colon cancers, skin cancer, prostate cancer. We're not making any of this up, it's really true. What do we do for him? We put him on minocycline, and he did great with his rheumatoid arthritis. So minocycline was studied in the 90s and early 2000s. This is one of our studies that showed the efficacy of minocycline compared with hydroxychloroquine, 60% ACR 50s. That's pretty impressive. Not only did these patients need hydroxychloroquine, but these patients were able to take significantly less steroids. We started everybody on steroids. We were able to taper it in the minocycline patients, not this. Effective therapy. It's not treating the bacterial infection that causes rheumatoid arthritis, but it has immunological effects. You know that because it can induce lupus in some patients. It inhibits metalloproteinases. It inhibits nitric oxide synthetase. There's lots of reasons why this drug works in rheumatoid arthritis. And so don't be afraid to use it in a niche of your patients. But know that the only data out there from the MIRA trial, which was an NIH-funded trial, from the trial in the Netherlands, and our series of trials were in seropositive patients. There's no data for this drug in seronegative rheumatoid arthritis patients. It can induce DNA antibodies and P-ANCAs and lupus. Never happened in an RA patient. It's never been reported in the world's literature in an RA patient, but something you should be aware of. Number one side effect is hyperpigmentation. And if you use enough minocycline for long enough, you will get this. In a high percentage of patients, the guy that I talked about with their RV had hyperpigmentation. He didn't care. He just wanted to travel around the country. When you stop the drug, this goes away. And that's important for you to know and for the patient to know. Sometimes it goes away slowly. When do you use leflutamide? Do you use it at all? Well, you should be using leflutamide, and you should use it for methotrexate intolerance patients. You should be using it in methotrexate patients, otherwise methotrexate patients that have CKD, or you should be using it in methotrexate nodulosis. So very, very well studied in the 90s, then it lost favor because the biologics came out. It's about equivalent to methotrexate when you use methotrexate at 15 milligrams orally. That's what the studies show from the 90s. So again, a niche therapy, a good therapy for a small group of patients. And make sure you're using all your tools. Doc, no matter what, I want to be able to go to work tomorrow. So what are we going to do in that patient? Well, we have several therapies that work quickly. Chief among those, of course, are the steroids. This is the first 14 patients that ever got steroids for anything in the whole world. They were from the Mayo Clinic. They all had ESR 50s. 100% of them had ESR 50s. In other words, their SED rates improved by 50% within a month. Steroids are very effective therapies. They have side effects in every one. We want to minimize their use, but if you have to use them up front, you need to use them. This is a study from Kerwin in the mid-90s that proved what we had learned in the 50s, but people didn't believe it because it was from the 50s, that steroids are very disease modifying. I'm not advocating that we use steroids in a high percentage of our patients. They're a bridge therapy. And if we can use them as successfully as a bridge because we have effective DMARDs and we can get people off steroids, and that should be our goal, getting everybody off steroids. Which combinations are more effective than monotherapy? All combinations are more effective than monotherapy and whatnot, but that doesn't mean, and here's from the premier trial that I showed you earlier, data from that, the combination of methotrexate adalimumab was more effective than either drug alone. So we should use combinations up front in everybody? No. So the TIER trial taught us that. Jason alluded to the TIER trial earlier. What do we do in the TIER trial? Well, we started off with methotrexate in a group of patients, or we started off with combinations, methotrexate etanercept, or the triple drug combination, methotrexate, sulfasalazine, hydroxychloroquine. And then if the patients needed excess therapy and if they're just on methotrexate, we put them in one of the combination arms, and all in a blinded fashion. And what do we find? Everybody did exactly the same. If we look at the window of a year to 2 years in terms of DAS28s, they all did really well. The groups that only got methotrexate up front and needed to be stepped up to the combination, and that was about 70% of patients, 30% of patients did well on methotrexate alone, never needed anything else. If they stepped up, they got a rapid response. And at the end of the day, they looked exactly like everybody else. And importantly, the radiographs looked exactly like everybody else. There was no advantage radiographically to starting combinations up front as compared with methotrexate. So what does that tell us? We should give methotrexate a chance in all of our patients, and if we do, we're not paying a price clinically or radiographically. Very, very important message from the TIER trial. The other thing the TIER trial showed, of course, was the combination of methotrexate and etanercept and triple therapy, methotrexate, sulfasalazine, hydroxychloroquine, are identical in terms of clinical and in terms of radiographic progression. Pregnancy obviously comes up a lot. The drug of choice in pregnancy or a patient wanting to get pregnant is always hydroxychloroquine. And don't think that this drug is not effective in RA. It's a very effective drug, again, in a niche of our patients. This is a chart. You can review this at your leisure and whatnot. There's no great data on a lot of these statements on this chart, but this is the best I can do with the data we have. And so you should be aware of this and whatnot. Okay, so here's the first 16 trials that were ever published on people who failed methotrexate, and then we gave them something else. And generally, they were on methotrexate, you gave them something else, compared with just keeping them on methotrexate, all randomized controlled trials. And you can see lots of marks here, better than methotrexate alone. So you can't read all these things down here, that's okay. Every therapy that we use now has been studied in that way, and it's always better when you add it to methotrexate than people on methotrexate who aren't doing well. But what we wanted to know was how to compare these therapies, and there have been very few trials that compare amongst these therapies. These are all conventional therapies, all the rest are biologics or JAKs. So what we did was a rocket trial, and you should be very familiar with this trial because there's a lot of patients who you put on methotrexate, and even if you do your very best, they still have active disease and you need to do something else. Should you add combinations of conventional therapy or a biologic? When we did this trial, we didn't want to keep people on a failed therapy if either one of these failed. So we switched them in a blinded fashion to the other therapy, and we asked the question who was doing better at 1 year. So the rocket trial published in the New England Journal in 2013. And what we found was that the groups did exactly identical. At the end of the day, they all looked the same. They all did quite well, and they looked the same regardless of whether they started on triple therapy or they started on methotrexate etanercept. So it was non-inferior with a high statistical significance. An important thing was some patients needed to switch in both arms. They needed to switch from one to the other. And so these are those patients. And when they did, in either direction, they got better. So switching from triple therapy to methotrexate etanercept improved people, and switching the other way around improved people. So the first data in the world that's ever shown after triple therapy, a biologic can be helpful. And it's the first data that's shown after a biologic, triple therapy can be helpful. Very important, the switch rate in both arms was 27%, identical, which would surprise a lot of people. To Dr. Weinblatt's comments about the tolerability of triple therapy, he said his clinical experience said that it wasn't very well tolerated. He cited a VA article. That has never been the case in any of the blinded trials that have done that. This trial I'm talking about, Rocket trial, the TIER trial, triple one therapy, the FIN-RA stuff from the 90s, triple therapy has been very well tolerated in a blinded fashion. So I can only say that that speaks to biases of people who are using medications. So there's another publication that shows in patients post-trial here, they were allowed to do whatever they wanted. And the majority of them, more of them stayed on triple therapy than stayed on methotrexate etanercept. tolerated well in the appropriate situation. Radiographic data from that trial, again, no difference, no benefit of methotrexate etanercept versus triple therapy. Very, very important data. You should know these data. So you're adding a biologic, which one are you going to add? Most of us are going to start with TNF, but we're not going to stop our conventional therapies, and that's really, really important. Don't do that. Once they get in remission or whatever, you might want to consider what you're going to stop. Are you going to use a monoclonal or a soluble receptor TNF? Are there differences? If you have certain situations, you're not going to use TNFs. You're not going to use that in a lymphoma patient or a patient with a history of melanoma or congestive heart failure if you have other choices, okay? You maybe wanted to decrease infection risk, or in somebody who's traveling to areas where TB is endemic all the time. All of those are going to color your judgment. What I want you to know is that there are clinically important differences amongst the TNF inhibitors. And one of our fellows and I published an article, and this is a very nice article to know when you're trying to get one TNF improved over another one, when you're trying to lobby the third-party payer for pre-authorization. Monoclonal antibodies are clearly superior with inflammatory eye disease, particularly in spondyloarthropathy, and drug antibodies are a problem with monoclonal antibodies and not with TNF inhibitors. I mean, not with the soluble receptor. Histoplasmosis, TB, all of these things are more common with monoclonals than they are with the soluble receptor etanercept. Very important to know. So active disease despite a TNF, what are you going to do next? Spin the wheel. Very important to know, there's this belief out there that if you're CCP or rheumatoid factor positive, that helps you select the biologic. It does not. It does not. The data that we've looked at shows that everybody responds better if you're CCP or rheumatoid factor positive to all of the biologics. It's not a selective indicator that you should be on rituximab or abatacept, as you'll see out there in the literature. So when you have patients who are refractory, you hope they're CCP positive because they always respond better than those refractory CCP negative patients. I don't have time to go through all the data on anti-drug antibodies. They are important. They're important for monoclonal antibodies and not soluble receptors. And the bottom line is that the patients on methotrexate, they're protected against anti-drug antibodies, not 100%, but 77% at the 77% level. And to my comments earlier, azathioprine does that, probably not quite as well. Other DMARDs, sulfasalazine and flutamide hydroxychloroquine, also do that. There's data from observational studies on that. It's not as good data as azathioprine and methotrexate, but know that, and that's another reason to continue them. If we get to this point where they fail the TNF, there's been lots and lots of trials on lots of different therapies, and basically you can get about a 50% response if you try them on something else. Very few trials head-to-head in this group of patients, but there are a few. There's a nice French study that was an observational real-life study, but what it showed was that when we're making a choice in a TNF failure, we're better off in most cases to go to a different mechanism of action than we are back to a TNF. There's some nuances to that, but that's the bottom line. And so that's what a lot of us are doing now. If they failed one TNF, we'll probably go to a different mechanism of action. So you got a patient in remission on methotrexate and TNF. What you're going to do, and Dr. Weinblatt covered this pretty nicely, what you're going to do is you're going to slowly space out your TNF injections, and the patient will find a sweet spot at maybe 12 days between their etanercept injections. I have a lot of people on every 3-month etanercept injections, etc. Are we going to use combinations of biologics? No. Okay. All the studies show us that very little increase in efficacy so far in the studies that have been done, and significant increase in toxicity, generally infections. So that's a no-no. I hope you all know that. Do we know JAK? Yes, one of the side effects is lightheadedness. Well, so JAKs are very efficacious, but we're still learning a lot about their toxicities. And one of the things that you will learn as you age and practice longer is that we learn a lot about drugs after they've come to market. We're still trying to figure out exactly the niche for JAKs in our patient population. Clearly very effective therapies. Here's some trials that have been done comparing biologics or JAKs to each other and some of the overall results. You can review this offline. Sometimes the problem is access or cost. Remember, methotrexate's dirt cheap, particularly if you use the injectable, and you can inject that or you can drink it. And same bioavailability to the oral if you're drinking it. Prednisone is also very cheap. This is unfortunately not an uncommon problem. Know that there are ways to treat patients cheaply. I'm going to just put up this slide here. Lipids are an issue. All of our DMARDs basically make your LDLs go up. They usually make your HDLs go up a little bit as well. But more importantly, when we treat people, their HDL function becomes better. Inflammation impairs HDL function, and we show this very nicely. Christine Charles and working with us from the TIER data showed this very nicely. Our therapies, when they control the disease, improve your overall lipid profile slightly, but dramatically improve your HDL function. Triple therapy does this better than methotrexate etanercept. So with that, I'm going to close. Happy to take whatever questions we have time for. I'm also happy to take questions offline. My email address is on the slide. I appreciate your attention.
Thank you, Dr. O'Dell. I think Jean is going to ask some questions to start off.
Hey, Dr. O'Dell, thank you for the very informative and evidence-based talk. We had a bunch of questions, and I wanted to start out with one on diagnosis and one on treatment. So the first question with diagnosis is for CCPs. Is there any time that you recheck the CCPs in someone who's seronegative? And then do you ever check it with like lupus in the concern that they might develop more like an overlap syndrome?
So yes. So CCPs, and particularly Jason and the other folks at Colorado have shown nicely that CCPs are present a decade before you develop your rheumatoid arthritis. So one of the beauties of CCPs is they're going to be positive when that patient presents. It would be a very rare patient who I would consider it worthwhile to repeat a CCP in if it was negative up front. The only time I would do that is maybe if I thought the lab was wrong or their disease changed in some way. Yes, I check CCPs on lupus. And, you know, we talk about lupus, you know, the overlap of rheumatoid arthritis and lupus, and it's a real thing. And those people are going to have more erosive disease. I'm going to tend to use more methotrexate than that lupus patient. And so, yes, I will check CCPs in lupus patients occasionally.
And the second question goes a little bit with therapy or side effects with methotrexate. Is there any point in how do you decide whether or not to use folic acid versus leucovorin? And is there evidence for like high dose folic acid versus leucovorin?
So I never use leucovorin, so that's easy. The only time I use leucovorin, it makes no sense to use leucovorin in the standard RA patient, none. And the only time I use leucovorin is if I have a methotrexate toxicity. Somebody's taken their drug daily, and that happens, unfortunately. Somebody has gone into renal failure, some other reason, and their methotrexate's accumulated. The patient comes in the hospital, that's when you're going to use leucovorin. In the standard patient out there in the real world, use folic acid. It's cheaper. It doesn't competitively inhibit absorption of methotrexate, so you can use it. There's some people out there think you can't use it on the day you take your methotrexate. That's baloney. You can use it every day. It doesn't competitively inhibit. Use folic acid. Sarah Morgan's data from the early 90s tells us we can use up to 4 milligrams a day without interfering with most of the efficacy of methotrexate. So use it daily and use it up to 4 milligrams. Most of my patients are on 1 milligram and they do just fine.
I had two questions came in about methotrexate and nodules. I guess the first question was, do you avoid methotrexate use if someone has existing RA nodules? And then a second kind of question is, can you tell the difference between RA nodules and methotrexate-induced nodulosis?
So the answer to the first question is no, I do not avoid methotrexate in somebody with nodules. There's no evidence that that patient is going to get a nodulosis syndrome on methotrexate. I wish we understood the nodulosis syndrome better than we do, but we don't understand it. But no, I would not avoid, somebody comes in with methotrexate and they've got nodules, some on rheumatoid arthritis, they got nodules already. Definitely, that's a good candidate for methotrexate. I'm not going to worry about that. Can I tell the difference? No, I can't, but I'm sure that some of the folks in Colorado can. Jason, if you can elucidate us on that. No, I wish I could. I wish I had a good answer there for you, but no, I don't. The characteristic methotrexate nodulosis patient is in total complete remission on their methotrexate, and why that's important, I don't know, but it just is the way it is. Again, in my clinical experience, because there's no good data on that, they're in remission. So if they have active disease, probably not methotrexate nodulosis in my book. But you have the patient, and a lot of patients will tolerate a few nodules, and a few nodules aren't necessarily a big deal. But if they're in places where they're bothering the patient, or they're tender, or they're sore, then that's when you want to do something different.
Maybe one more question for Jean.
Yeah. So I was hoping that you could I was hoping that you'd comment a little bit about minocycline. Do you always use it as monotherapy, or is it ever used in combination therapy?
Yeah. So thank you for asking that. And again, I want to emphasize it's a niche of patients, but for those patients, it's absolutely a wonderful thing. We use it as monotherapy in some situations. More commonly, I use it in addition to something else. Particularly, we did data. There's a study published in 2002, I think, on the use of methotrexate and minocycline together and increased efficacy. And also methotrexate doxycycline. So doxycycline works probably as well as minocycline, but there's more data in minocycline. The advantage of doxycycline in those patients is it does not cause hyperpigmentation. So if we have a patient doing really well on minocycline and they have hyperpigmentation issues, you can switch them to doxycycline and the pigmentation will get better. Again, a small niche.
Okay. Thank you so much. I think that might be all the time we have for questions today, but we very much appreciate the talk, and there's a lot of wonderful comments thanking you for the talk as well.
Well, thank you, and I hopefully at least I've been provocative. Have a wonderful weekend, everyone.
Thank you.